Thank you. Good afternoon, and thank you again to the members of the press who are on the line and taking the time to listen to this briefing by the Pan American Health Organization on the influenza A H1N1 outbreak. Today I'd like to review three burning issues. First, there have been a lot of questions about the severity and clinical presentation of this disease. Why does the disease appear to be more severe in one state or another country compared to another? To make comparisons, we need to be sure we're comparing apples to apples. We need to be sure the case definitions are the same, and we need to understand what the denominator data are. Denominator data allows us to make determinations like the following. 5 cases spread about New York City is quite a different situation than 5 cases in a small island republic. These factors are very important to understand the nature of virus transmission and its severity. This may explain some of the differences, but we know other factors such as the presence of underlying disease conditions will put people at greater risk for more severe disease. To that end, to learn more about the current situation, WHO convened a global teleconference call with some experts from around the world to discuss these issues of severity and the clinical presentation of this disease. I would like to share with you some of those conclusions coming out of the discussions. With regards to clinical presentation, we know that so far, most of the cases are occurring in young adults. The median age of cases we're tracking in the Americas come around 22 or 23 years of age. By definition, meaning that half the cases are less than those years. In the United Kingdom, another country recently infected, their preliminary data also are consistent with what we find, around 25 years of age for a median. And they're also finding, like we're finding, far fewer cases above 40 years of age. We know that a substantial proportion of the cases being reported at this phase of the outbreak also have a traveling history to affected countries. We also know that young adults are more likely to travel. So all these factors contribute to what we're seeing. In addition, we also know that influenza in general, seasonal influenza, tends to go to the younger age groups first before entering the older populations. Second, the information and knowledge we're acquiring on how to control this outbreak is constantly evolving. Some months ago, we thought the global capacity to produce seasonal influenza vaccine was around 700 million doses per year. We now understand that that capacity may be closer to 900 million doses. Companies have geared up. There's been a lot more attention in the last few years to increasing capacity. In addition to that, with information we've gathered through several meetings with manufacturers and through the review of several reports, we project that the current capacity to make H1N1 vaccine over the next year will be 1 to 2 billion doses. What we've also learned is that a significant proportion of that potential vaccine capacity is already tied up in pre-production contracts with the 4 largest producers of the world. PAHO and WHO are working very hard with these manufacturers to ensure substantial and equitable supplies are available for developing countries, not just in the Americas, but for around the world. PAHO and WHO are also catalyzing support to what we call emerging market manufacturers, who may be able to produce substantial quantities of vaccine if provided the proper support. Such work is taking place, for example, in Butantan, Brazil, Serum Institute of India, and Bio Pharma of Indonesia, to name a few. So what does this all mean essentially? For us here in the Americas, we are not certain how the risk assessment of this virus will evolve, but we know that its management will be a long-term challenge, and it has to focus on preparation and prevention. So with the southern hemisphere countries entering its winter flu season, there is a strong likelihood that there will be a substantial increase in the number of cases occurring in the southern hemisphere countries. So to that end, pandemic plan implementation with a focus on preparation and prevention is critical and is already being done. So I'll stop there and entertain any questions that you may have. Thanks again for taking the time.
Thank you very much, John. Let's start with the first question, which we got from the German news magazine Focus, from Silvia Sanides. She really has 4 questions, but let's start with the first one, which is, what is or was the role of Canadian and US CDC health authorities in helping Mexico?
It's a very good question, because both Public Health Canada and the U.S. Centers for Disease Control and Prevention from Health and Human Services are 2 very long-standing partners of the Pan American Health Organization, and they were ready at the very beginning to collaborate with us and go to Mexico as part of the scientific team that initially went to the country to help our colleagues in the Ministry of Health Mexico deal with the issues surrounding with this outbreak, and in particular the control of the epidemic.
And then she asks, what is the consensus about the reaction of Mexican health authorities? Was there a timely and correct response? Has there been good cooperation with the U.S. and Canada?
I, to that question, would only repeat what our director, Dr. Mirta Rosas, and the Director General of WHO, Dr. Margaret Chen, have reemphasized in a number of press conferences and a number of venues, that the response from Mexico has been outstanding.
Okay, great. Okay, and then I know we had a question from a Canadian journalist about the statement on the safety of pork, whether it is still safe to consume pork products.
That's a question that I'll just go right to the bottom line at the beginning. Pork is safe to eat. Maybe it would be useful for me to describe in more detail why. And the reasons are, this virus survives just for a few hours outside a living cell. And with that, that alone would explain why pork would be safe to eat. But in addition, there's processing materials when procedures that come from meat that's been slaughtered. And so that processing, plus the time it takes to get to the markets and the fact that it may be frozen, all those factors get to the bottom line that this is not an issue. Pork is safe to eat.
Okay. Thanks, John. And then we have a question from California about, she calls it the pulmonary chain reaction device, but I think it's the PCR test.
Okay.
And she wants to know how we use that in helping doctors detect patients with the virus. How is it a faster test than other tests we have available for confirmation of the virus, and how long does it take?
The PCR test stands for polymerase, if I can say it correctly, polymerase chain reaction. And this is a test that uses a genetic technology to determine that the agent is the H1N1 virus. It's a very sensitive technology, so it benefits our pursuit of this disease and defining the extent of the outbreak, because it is sensitive. And its length of time to produce results is much quicker than the traditional procedures. And we've had experience with this test over the years. In the case of polio eradication, it was very, very essential in the Americas, using this kind of technology to help us eradicate polio, and more recently measles and rubella, and now with the control, identification and control of this outbreak.
Okay, thanks, John. We have a question from a journalist for Xinhua, the Chinese news agency in Mexico, saying that if we could give an opinion on the Mexican Health Ministry's report that the 77 people who died with symptoms consistent with AH1N1 flu will remain as suspicious deaths and never be confirmed or ruled out as AH1N1 deaths, and what reasons might cause this number of samples that are unusable or unclear, and how many suspicious cases, or is it common for suspicious cases in other countries not to be necessarily identified in numbers and percentages?
If I understand that question correctly, it's a complicated question, and it's related to the response of a cluster of people dying and how, when in a situation you don't know the etiology, what do you do? And what the bottom line is, you do your best, and that's indeed what the Mexican authorities did. And given the cluster of deaths, given that they had suspicions, they used their clinical and scientific acumen to follow those suspicions, and the result we know today was the identification of this outbreak in Mexico. So I don't think that, I believe that everything is being done to determine the cause of death, the etiology of all those cases, because that will help us better understand the nature of this outbreak. And I also believe that I wouldn't say that 100% of those deaths were caused by this virus. Some proportion we'll find were caused by the virus, but there were other conditions, and there are other viruses that cause serious illness. One patient, an isolated case in the sense that it was reported in Oaxaca, was a woman that they originally thought might have died due to coronavirus. So the differential diagnosis when you see a patient is very lengthy, and so bottom line, I think they did everything they can and are doing and continue to do that in trying to exactly identify the etiologies.
Okay. And then we have another question from Claudia Ramirez Blas, who asks, I think, a question that's probably on everyone's mind. Do we know where this AH1N1 outbreak originated?
I don't think we do. I think that will be work that, you know, I believe we have some of the best scientists in the world working on this, and that it's going to take time to investigate all the information in lieu of the fact that at the same time we're focused on going forward and controlling the outbreak. So you have, in a sense, scientific research that's ongoing, being conducted by some of the best scientists in the world, at the same time trying to balance that with doing the immediate measures needed to control this outbreak and get on top of things.
Okay. And now we have a question from Doris Gomora of El Universal, a major newspaper in Mexico City. And she asks if PAHO has any kind of pre-contract with new vaccine manufacturers, or how PAHO is really working to get vaccines for Latin American countries.
For that's an excellent question, and we've been thinking and working on this issue for a couple of years now, recognizing that a pandemic, and this was the language being used 2 or 3 years ago, that it wasn't a question of whether a pandemic was coming, it was a question of when it would come. And our understanding at that time of the global capacity was such that it was much less than what I reported today. So we have initiated work that would help catalyze transfer of technology. I mentioned Butantan, Brazil, where I think it was the Gates Foundation. There was a significant contribution to the agency there to upscale its capacity and begin using the technologies to make influenza vaccine. So a lot of work has gone into it. I think we now are at a phase where we can begin really locking up contracts and negotiating prices. But again, this is for something that is yet to be developed. We have no vaccine in hand, so this is really new work. We're breaking new ground by doing this. So we just had a conference call this morning with the Global Vaccine Task Force, and this is a key recommendation coming out of it. Continue supporting the initiatives like the emerging market work that I mentioned, and in addition, with those 4 large manufacturers, firm up negotiations, firm up commitments and contracts for all the countries.
Okay. And then we have excuse me. We have another question from Kip Eidenberg that I think you answered already relating to pork safety, but I can add to this. She asks that today Reuters reported that WHO cautioned that meat from pigs infected with the new virus shouldn't be used for human consumption. And I can tell you that we talked to the media people in Geneva, and that that was a misinterpretation of what the food safety director in Geneva, Jürgen Schlumpf, said, and Reuters is going to issue a clarification. So your answer that pork is safe to eat stands. There's been no change in position. The other question we have is from the person in Mexico who was asking about what types of measures can we take to lessen the impact of this virus on the tourist industry, if any.
That's a good question. We balance risk interpretation and communication with what happens in the real world, and no one was saying that to close borders. No one is saying do not impose travel restrictions. It's just, it's really recognizing what we can do as individuals to protect ourselves. And we have a team of experts going to Mexico City tomorrow to provide additional support to the Ministry of Health, and those experts are going with that clear understanding of frequent hand washing and using a disposable tissue and all those things you can do to protect yourself and still be productive and support the Mexican authorities. So I think there's no perfect answer to your question, but I think that it's reasonable to say that if I were going on holiday tomorrow to Cancun, I would go.
And then now we have another question from Jessica Naziri, who is asking for specific information about how Los Angeles County is prepared for this virus, but I think we could make that a generic question about how counties and states in the U.S. have prepared for this virus. And she asks really, what is the worst case scenario?
I'll address that first one. We have a great team of risk communicators at PAHO, yourself and Bryna Brennan and others, and it's really about working with communities. So at the county level, it's working with your communities so that contingency plans can be developed. It's working with the family level, that families that over dinner talk about, well, what if I was to get sick tomorrow? What would we do? You know, what if Elizabeth gets sick tomorrow? Should she go to high school, and so on? And what would we do to cover our responsibilities and lead reasonable lives? So that's very, very important at the county level. A county as sophisticated or as large as Los Angeles, with millions of people, it has a network of surveillance and public health field workers that would also be involved and engaged. They would have risk communication in place. They would have their laboratories geared up. So all those things that go into the implementation of an emergency plan at the county level is really closer to the community and to what families can do. So it's think globally and act locally.